And thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I am Kathy Riley, the Associate Director of Programs at CSCLA, and I'm really honored to welcome you to this week's webinar titled Pediatric Cancer, Neuropsychological Testing, and School Reintegration. And before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. So if you'd like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. And before I introduce our speakers for today, just note that your video and microphone are automatically disabled for this webinar, but we really encourage you to enter your questions into the Q&A feature that's found at the bottom of the Zoom window at any time. And questions will be answered at the end of the presentation. We may not be able to get to all of your questions, but we'll get to as many as possible. So I'll go ahead and introduce our speakers. Bridget Vazquez is a clinical psychologist at Jonathan Jaques Children's Cancer Institute, MemorialCare, Children's and Women's Hospital. She provides a wide range of services to pediatric hematology oncology patients, including consultation, psychotherapy, neuropsychological assessment, and reintegration services to facilitate a smooth and supportive transition back to school or work. Dr. Vazquez supervises doctoral level practicum students from APA-accredited doctoral programs. Her clinical and research interests include pediatric health psychology, testing and assessment, trauma and trauma-informed care, culturally sensitive forms of coping, and diversity and social issues. Grahamm Wiest is a licensed psychologist and clinical neuropsychologist specializing in providing evidence-based neuropsychological evaluations across pediatric and adult populations. Dr. Wiest received his doctoral degree from California School of Professional Psychology in Los Angeles, California. He has advanced neuropsychological training in a variety of settings and hospital departments. He completed training at Children's Hospital Los Angeles, where he worked in traumatic brain injury and epilepsy. He also completed additional pediatric training at Miller Children's Hospital, where he provided neuropsychological service, consultation liaison psychotherapy, and outpatient psychotherapy through Jonathan Jaques Cancer Institute. And his current practice focuses on evidence-based neuropsychological assessment across the lifespan, including neurodevelopment disorders such as autism spectrum disorder, language disorders, and attention deficit and hyperactivity disorder, to adult neuropsychological exams, including neurodegenerative disorders. And it gives me the greatest pleasure to welcome our speakers today, Dr. Bridget Vazquez and Grahamm Wiest. All right, welcome.
Hi, good afternoon, everyone, and thank you, Kathleen, for that lovely introduction. Just before we get started, we'd just like to extend again our sincere gratitude to Cancer Support Community LA for inviting us onto this webinar. And just give me a second here. I will share my screen and we'll get started. That works. Okay. All right. So before we get started this afternoon, for disclosure, we have no actual or potential conflicts of interest with respect to this presentation for this webinar. So we have three primary objectives for this afternoon's presentation. The first is to go over a couple of the common cancers that we treat here, their treatment, as well as going over late effects associated with these oncology treatments. We'll next go into discussing neuropsych testing in pediatric oncology as part of standard of care for as part of the Children's Oncology Group guidelines. And then we'll also talk about, next steps after treatment or diagnosis and, what school reintegration looks like. So, this list here it's not a comprehensive list, but these are some of the more common types of childhood cancers that are seen in pediatric oncology patients. And the Children's Oncology Group, their family handbook, does just a really beautiful job in outlining these cancers and really using simple, digestible language to go over what each cancer might look like, its presentation, and how it's diagnosed. But just as a quick overview, some of the more common cancers that we see are leukemias, which are cancers of the blood, like ALL and AML. We also see cancers of the brain or central nervous system, like brain tumors, like medulloblastoma. We also see cancers of the lymphatic system, so lymphomas, as well as cancers of the bone, the muscle, or organs, or other tissues in our body, which are known as solid tumors. And here's a list of a couple of the solid tumors that are more commonly seen. Now, each type of cancer has its own treatment and its course. And, when deciding on treatment, it's a shared goal, right? It's a shared goal between our patients, their caregivers, and the treatment center. And we've listed out a couple of the more common treatments that we see, but depending on the diagnosis, it might be one treatment or a combination of many types of treatments. So like, for example, like a patient with leukemia might just receive chemotherapy and surgery with a port placement, or a patient with a brain tumor might receive surgery, chemo, and radiation. So it's really dependent on the nature of the cancer and treatment outcomes as informed by COG guidelines. Some of these treatments, like chemotherapy and radiation, have side effects, and Dr. Wiest is going to spend a little bit of extra time going into what is known as late effects.
Thank you. So the wonderful thing about what we've come so far in terms of treatment is that mortality and morbidity are down. And so there's a trade-off, and the trade-off is something called late effects. And the discovery and sort of the development of these chemotherapy agents have really increased cancer survival. And these late effects basically affect the neuronal damage. So chemotherapy can impact neuronal damage and can really make the repair and remodeling of the brain challenging. And so one of the biggest effects that we see are in white matter areas. And what white matter is these subcortical myelinated areas that are sort of these connection junctions. They're subcortical, and so they connect parts of the brain with other parts of the brain. They transmit information across the brain. And what that can do is significantly decrease some aspects of intellectual functioning. And what intellectual functioning really refers to is our logical problem solving, our learning, our verbal skills, and our planning. And with that also is the ability to mentally manipulate information and do things quickly in our mind. So what you'll see sometimes with chemotherapy and radiation is a patient who comes in, very typical, and then after radiation, they seem to take time to like mull things over, or they take a little bit longer to sort of understand and process information. And that is sort of what we call late effects. And we call them late effects is because they often present about 2 years after treatment. And so that's kind of why we really want to make sure that we're tracking neuropsychological function, not just in a qualitative way of how they seem and appear, or sorry, we want to track it quantitatively on paper through neuropsychological testing. And so what a neuropsychological exam does in the course of cancer treatment is help us track and monitor neuropsychological status and neurobehavioral status over time. Dr. Vazquez, can you go to the next slide? These are some common, I would say, areas of impairment. So processing speed was one, memory is another, and these areas are all mediated by attentional deficits. So not only are children a little bit more distractible after treatment, maybe a little bit overwhelmed, but really what the breakdown of the white matter tracks do is it limits the amount of attentional resources that can be used. So when especially in pediatrics, these limited resources, they can only filter so much information at a time. And so if somebody is presented with several pieces of different information, they might only pick up one or two rather than 4 or 5 that they might have previously been able to access. And that makes sense in terms of how we sort of think about attention in general. So there's some sensory information that we see or hear, and we have this attentional filter. And that attentional filter will either throw it out to be discarded, we don't need that information, or the attentional filter will say, you know what, we do need that information. Let's pass it into short-term working memory, which then gets processed into long-term memory. So that's our model of how attention fits in sort of our theory of cognitive neuroscience. And when attention is a challenge for these patients, and we have memory deficits like difficulty remembering things and forgetfulness, that makes it really hard for children to learn information, to access that information for the ability to perform well in the classroom. So that's how I call it the attention bottleneck. It's sort of this small little tube that information has to pass through for it to be disseminated throughout our neurocognitive ideas. And that's where this bottleneck makes it really hard. And that's where the late effects really show in our patients. Next slide, please. It also affects our executive function. And people often ask, well, what is executive function? And it's sort of this broad idea of higher level or higher order thinking, the ability to follow multiple steps, to be flexible between tasks, to start things. Executive function is often following multi-step directions. In children, it's brush your teeth, get in the shower, have breakfast, and get in the car, get ready for school. And in adults, it might be finish this email, complete this task, but first you have to do this. So it's this higher order function that is really located in the brain and sort of this frontal lobe or prefrontal cortex. And in our pediatric patients, well, that prefrontal lobe isn't necessarily fully developed yet. And so executive skills are some of the things that we really monitor very closely to make sure that that these patients are really regulating their ability, because it also has to deal with emotional challenges as well. Our ability to regulate emotions is also a part of executive function. And so these are just some common ideas of what executive function is. So need for frequent repetition of instructions in the classroom, difficulty following multi-step tasks, flexibility, doing things in between activities, and then starting. That idea of initiation is something that we see a lot in brain tumor and with tumor resection is trouble with initiation and getting started. They don't know where to start. And once we put them on the right path, oftentimes they can do really well, but they have to learn that skill or relearn it just to be able to do that. Problems with planning, self-monitoring, and problem solving, and then challenges with regulation. So overactivity and impulsivity, these are all things that are really affected by the late effects of treatment. Next slide. And this deals right into what we deal with a lot in the pediatric side, which is the school reintegration and the learning challenges that these patients often deal with. So reading is a higher order task. It's not just the sight word, we're past the phonics, but it's applying written information into a paragraph and then problem solving into, well, what does this paragraph actually mean? How does this character feel, do you think? What did they say back in the first paragraph? And this patient maybe is reading on the fourth paragraph. Mathematics is also a higher order function. Once you get down the basic fundamentals of addition, subtraction, it goes into higher order and more problem solving, where you have to solve one part of the math problem first and then do the finishing part next. I was just working with somebody and they wrote PEMDAS on their math workbook to jog their memory of them doing math problems. And they have to know that mnemonic first before they can incorporate it. Writing is also the main part of learning troubles. Writing is problem solving, it's the fine motor component, and it is putting ideas onto paper. And that, again, also deals with our visual spatial problems, right, left, issues, problems combining letters to make a whole word, and then difficulty with perception. And I think it's important to understand that there is no one neurocognitive profile of pediatric cancer, because it really all depends on tumor location, and we can get to that later, but these are just some examples of these late effects and where they deal with from a neurocognitive perspective. Next slide, please. So a diagnosis of childhood cancer can really have a devastating impact on not just the emotional health and well-being of our patients, but also the whole family. And it's not just right during treatment, but after treatment as well. It's dealing with survival and what that looks like after 5 years, 10 years, and into life. And really what COG has talked about, or Children's Oncology Group, is the sense of grief at the loss of a normal family life. These children really have a hard time, and their families really have a hard time of adjusting to this medical situation. And oftentimes it's really a disruption to normal life. And COG has also talked about that parents often feel that they're not given enough information on how to help or how to cope with the emotional distress and shock at the diagnosis. Just this year, I've heard parents come in and talk to me and how sudden and uprooting this diagnosis can feel. For example, one came in and talked about they went in for a routine check on a Friday and were in surgery for tumor resection on a Monday morning. And so it can happen that fast. Another patient comes in for blood work for a football physical and is told they have leukemia and have to start chemotherapy right away. So that really places you at risk when you're a typically developing child or adolescent, and your life becomes uprooted and your life becomes the hospital. And these late effects of treatment really are causal in increasing anxiety, in somatic symptoms like body aches, tummy aches. You don't know if it's the chemotherapy drugs or if it's your body's stress reaction, um, suicidal thoughts and wanting to die, and behavioral problems as well. In younger children, often that's how behaviors manifest, is throwing markers or hitting nurses or behavioral problems at home, both inpatient and outpatient. And this can really create some social and interpersonal difficulties as well. You're isolated from your peers, you're isolated from your friends, you're in the hospital, and life is just very, very different. So that's really another big blow to these kids, is it's not just the effects of the treatment, but it's the psychiatric underlay that are often seen in this care as well. Next slide. So what causes the neuropsychological late effects? Like, what is this underlying issue here? And basically, there's some neuropsychological dysfunction that is secondary to the radiation or the chemo. And it predominantly is from cortical and subcortical, like I said, white matter damage. And those demyelinating processes destroy cells, basically. And MRI has really shown that the volume of white matter declines over time from the start of radiation through radiation treatment. And with a decreased volume of white matter, that means that certain processes like processing speed, like working memory and attention, goes down. And that's been correlated with IQ decrease as well. And so this insult to a developing brain and the cranial radiation causes specific damage to the brain and the related structures. So if you have a tumor near the frontal lobe or the temporal lobe, you might have some language challenges. And pituitary gland, you might see some eye-related movements or challenges. And maybe in the back of the brain, there's some processing speed deficits or some balance issues. And it's really tied to those neuroanatomical correlates. And the central nervous system is directs basically the chemotherapy, and it can cross the blood-brain barrier, and that's how it sort of gets into our system and destroys cells. And like I was saying earlier, the tumor resection, depending on the location, can result in excessive brain tissue being removed. So in order to save the patient, you have to give up a little bit more brain tissue, which is related to the neuroanatomical correlates of that area. And so what helps? What are some of the, well, I'll say risk factors, and then what are some protective factors as well? So the cancer severity obviously is a big risk factor, and the tumor features in terms of how deep or how subcortical. Do they have to pull more tissue or less tissue? Comorbidities and pre-existing conditions like pre-existing ADHD or pre-existing autism spectrum disorder or intellectual disability, other health complications like a brain bleed or anoxia, lack of oxygenation to the brain, as well as age, sex, and socio-demographic factors like younger children are higher at risk for more adverse impact. So the younger you are and the bigger the tumor that needs to be resected, or the more intense the radiation is, the more complications are likely to be had. It also depends on the type of treatment in terms of the dose, the type of chemotherapy, the type of radiation, and then any surgical resections and complications that need to be had. And next slide, please. Yeah. And so these are some other I'll say, psychosocial or protective factors. So early childhood development, if a child is really on track and acquires leukemia and needs to go through some chemotherapy and has really done well with treatment and has a loving family and has done well neurocognitively throughout, they're likely to have a better outcome. So these precancerous level of functioning, the educational experiences that they've had, that's why school reintegration is such an important part of this, is having the support of the school, having the support of the family, socializing and social engagement, the ability to have friends who come and visit, to be social with others. Those are really important things. How well they can adjust and cope is a big thing that we see at our hospital when we see patients bedside, is are they able to adjust? And that's a relative term, obviously, but how well are they able to handle and grieve appropriately so, and engage in psychotherapy and in physical therapy if they have it, or educational rehab? And how well is the family integrated into those services, really play a role in how are these children and these families going to get once they're in survivorship? And that's a really big deal as well. Next slide. And so what are the common diagnoses that we see, or that we will diagnose when we see these patients in clinic for neuropsychological testing? And it's good to have a baseline following primary treatment and after acute symptoms have resolved. And that typically coincides with the transition back to the school environment, which is about 1 to 2 years after treatment. And this is what we see when we see late effects is, well, has it interfered with any areas of function, whether that be language or visual spatial skills or processing speed and working memory? And we have basic paper pencil testing or iPad-based testing that can measure these different areas of function. And our most common diagnosis that we will see is what's called mild neurocognitive disorder. And that's basically a modest decline from a previous level of performance in a range of cognitive areas. And it does not interfere with independence in daily activities. And what does this mean for children is maybe a decrease in memory, but all other areas are okay, and they're independent in their ability to tie their shoes, complete basic tasks, go to school, have friendships. That might be a mild neurocognitive disorder. Major neurocognitive disorder is a decline from previous level of function in a variety of areas, and it does interfere with the capacity to complete daily living. So a child has a tumor, the tumor is taken out, they underwent radiation, maybe a proton beam, and it was really focused and high intensity. And the child survives, but there's some, the trade-off is a major neurocognitive disorder. And this child may need a lot of assistance completing basic activities of living, and may need behavioral therapy, and may need physical therapy and occupational therapy. Their speech and language might be significantly impacted, and their ability to toilet or complete basic problem solving may never improve, and they may have a lot of significant challenges. And that's why diagnosis is really important, is so that these patients can get the services that they need through the state. And that's why we do these neuropsychological exams, is to help measure, well, how much support do they need? And will they need more or less? And as well as to monitor and track the neuropsychological status over time. And so these are the two most common that we see. And we can go to the next slide. Yeah, and we also see some issues with specific learning disabilities or specific learning disorder. And that is basically what I call unexpected underachievement. And like we were talking about with the attentional bottleneck, is these patients have a very hard time and limited cognitive resources in their ability to attend to information. So they have to pick up the most salient things taught, because they might not be able to cognitively hold all the other information in mind. And so a specific learning disability is trouble with writing, reading, and mathematics. Those are the three big areas, and part of what we incorporate into our neuropsychological testing is to really make sure that we're finding out, is learning been impacted from treatment? We will also diagnose ADHD if it presents premorbidly or before the fact. And ADHD is a persistent inattention or hyperactivity or impulsivity, and it really interferes with everyday functioning. So a kid may be bouncing off the walls or climbing on a bookcase or under the desk, and it occurs in more than just the office. It occurs at home, and we try to get information from parents and teachers to really make sure that we're understanding their presentation. And similar features with neurocognitive disorders. So it's really a neuropsychologist and health psychologist's job is really specialized in how do we tease apart these diagnoses to provide proper intervention and treatment. All right. Excuse me. So what do we do then? We have these neurocognitive profiles. We went through the testing, and what do we do then? Because pediatric cancer treatments may disrupt normal brain development, and they basically places these survivors at a risk for the emergence of these late effects. And that affects patients when they go back to school. Next slide, please. And so we sort of already talked about it, and I want to make sure we're getting more time to other areas, but these are the basic areas that we test when we do a neuropsychological exam. And it's targeted in all these different areas of attention, or sorry, intelligence, memory, attention, executive function, language, academic achievement, visual, spatial, and perceptual abilities, behavioral, emotional, personality, and then adaptive abilities. So these are all the different areas that we look at when we do a neuropsychological exam. And why do we do it? Well, we've kind of already talked about it, but basically to understand an individual's functioning, to evaluate their skills, whether immediately following treatment or maybe before treatment, if we can do that. But it really evaluates their in the moment strengths and weaknesses at that time and helps guide and inform our diagnosis. It also helps create goals for the medical team, for the school, and for the family. And we write our recommendations in a written profile, and it helps inform treatment planning and accommodations. And the written report is the bread and butter of neuropsychology, and really helps provide assistance and help to these families at the school, at the home, and medically. Next slide, please. And so I think, Dr. Vazquez, is this you?
I think this is still you, Dr. Wiest.
Oh, sorry, I apologize.
No problem.
So in terms of academics, the treatment side effects, the psychosocial stressors, and school absences during and post-treatment significantly can impact learning and educational outcomes. These patients are in the hospital often and consistently, and they miss school, and families want to accommodate. And so what we do in our clinic is really collaborate with public schools and write letters for our patients in addition to reports, connecting them with private schools if need be, or charter schools, and communicating with colleges and universities, making sure that our patients' needs are met, so that they have a free and accessible educational experience. So we collaborate and coordinate with school services, the hospital, school and the family, really providing tools, strategies, and resources to, like I said, get our families the resources that they need and accessibility between school and home.
Thank you, Dr. Wiest. All right. So, just like Dr. Wiest had mentioned, many of our pediatric oncology patients miss a substantial amount of school not just during treatment, but even post-treatment, right? Survivorship comes with a lot of follow-up appointments, and sometimes unexpected bumps along the way. I have to say that one of our most common and shared experiences by many of our families is just like where to prioritize school in the middle of treatment, and what resources are available to them to help educate not just the staff at school on our patient's medical condition and their treatment and side effects, but also develop a plan to really ensure that there is continuity of care at the educational level. And so one of the things that our team does here is providing our caregivers information on resources that are available at the school level to help advocate for those needs. So one option for many of our patients to pursue is what is called a 504 plan. And this is it's an educational resource. First of all, let me back up. Actually, it's a law that applies, and most, if not all, of our patients qualify for this. It's a federal civil rights law under Section 504 of the Rehabilitation Act of 1973. And it's intended to stop discrimination against individuals with disabilities and, again, increase access to reasonable accommodations at the school level. Whether if that means an excused medical absence or really being able to provide them support like an extended time on an exam. And so, again, all of this is in the function of really supporting the academic achievement of our pediatric oncology patients. It's typically initiated by a caregiver and reviewed by the committee. It might include guardians, it might include, individuals that are familiar with the student, a principal, a teacher, a nurse, anyone that might have a good understanding of what's going to help make this child successful. Oftentimes we participate in some of those school meetings as well, really integrating some of the findings from neuropsych testing to help form some ideas of what is a reasonable accommodation. For our families that do qualify for the 504 plan, it's typically reviewed annually, and revised as needed. And then I think a common question that often comes up is, what if my child goes to private school? Can they obtain a 504 plan? And we always encourage, again, communication and collaboration with the school to determine what resources are available. For example, private schools that do receive financial assistance from the federal government are covered under this law, and so therefore would be eligible for a 504 plan. An alternative is also what is called an individual health plan. It's an IHP. Again, this is similar to a 504 plan in that it's a written plan between a nurse at the school, the student's guardian, basically outlining, my child had cancer, this is their treatment, and if they're still actively on, for example, maintenance chemotherapy, it might be coming up with a plan for if this child is exposed to infectious disease or develops a fever, what to do, next steps. This IHP can be integrated as part of a 504 plan or an IEP. An IEP, on the other hand, is more tailored to the student's individual and specific needs, right? This is covered by a federal special education law, abbreviated as IDEA. And the basic premise is that this child needs more specific and tailored intervention beyond what can be provided in a general education setting and cannot be covered by a 504 plan. So really it's helping the patient qualify for special education and related services to meet the needs of that particular student. So for example, if one of our patients had a brain tumor and then had substantial late effects impacting fine motor skills, and now they need occupational therapy as part of an accommodation, right? They might be eligible for an IEP under other health impairment, for example. So this is typically initiated by a caregiver. Written request is mandatory to get that process started and start that timeline. So just a quick overview. Really what the school does is conduct an independent evaluation. If the child is found eligible for services, then they are found eligible in either one or more of the 13 categories. Reevaluations typically occur every 3 years to see if there's been any changes. Whether if a student needs more services or maybe they're ready to exit out of a service. That is the purpose of a reevaluation. And typically our patients are eligible for all of their IEP services through age 21 or until high school graduation. Okay, so these are just some common accommodations that might be provided under, for example, like a 504 plan or an IHP. For our patients that are pursuing college or university, there is support there as well. It's often called student program and services. Each college and university oftentimes have their own application process, but for us, we provide supporting documentation for our patients, documenting their medical condition and what might be a relevant accommodation. It's helpful that if a patient already had like a 504 plan or an IEP during high school, that plan transition and carry over at the college or university level as well. And then Dr. Wiest for neurocog rehab.
Yeah, thank you. So there's been a lot of advances in cognitive rehabilitation. This was a big focus of my early research, and something that I think we're building into our program at Miller Children's is the computerized cognitive training aspect. And what that does and what we've seen is it really helps improve near transfer areas. So areas of attention, areas of executive control, and areas of processing speed. We've really seen really good improvements in those areas using things like CogMed or RehabCom or Mind Builder, or Lumosity is another one that's free or used to be. But there's been a really increase, I would say, in the literature of showing how these computerized cognitive training models have really built these skills. They build them through learning strategies and organizational strategies and self-monitoring, and there have been global improvements in working memory, attention, and executive function. The research, I should say, is limited to near transfer areas and doesn't generalize to far transfer, things like language and math and other areas of processing speed. We don't see it as much, but if we really want to work on working memory and attention, these interventions are helpful.
Okay. Thanks, Dr. Wiest. All right. So we're approaching the tail end of our presentation here, but relevant to everything that we've talked about, from initial diagnosis of cancer to going through treatment and potentially developing late effects. Mental health is just equally as important and related. earlier in the presentation, Dr. Wiest talked a little bit about how many of our oncology patients are at risk for developing, anxiety, depression, even traumatic stress. And I think, it's important to do ongoing screening for these types of signs or symptoms because of their potential impact, right, on academic functioning, on employment, on just daily living. I know that many times our common referral questions here for therapy are kiddos worrying about being asked by their peers or being bullied by their peers because of hair loss secondary to chemo, or maybe they were typically developing in some way before treatment, and then all of a sudden there's a regression. And now, being worried, being compared, to their peers or friends, or being asked questions on how do I answer questions about why I've been out of school for so long, and what if I don't want to talk about it, or how do I approach questions of like, why do you get extra time on a test? Why do you get special treatment? And so all of these questions are, appropriate, and unfortunately, oftentimes internalized by a lot of our kiddos. And so we really try to focus on helping promote open conversations in therapy about these concerns, and really building up skill set to help them navigate anxiety, depression, or concerns about school, helping them feel that it's a very supportive process, and that going back to school will feel supported. We practice from a biopsychosocial perspective here, and the more people that we can get involved, reaching out to different systems involving parents, teachers, sometimes even doing other advocacy work has been really beneficial to promoting health outcomes for our patients. There is a lot of new and upcoming research on different evidence-based interventions, such as acceptance and commitment therapy for this population, cognitive behavioral therapy. One of the manuals that we use is called the Coping Cat, as well as implementing mindfulness-based interventions. Similar to kind of building up executive functions and different parts of cognitive functioning, there is an increasing amount of research on mobile applications and how that can help increase skill building, especially for patients that might not be ready to start therapy. There's a lot of free apps out there that teach on breathing and relaxation, meditation, using imagery to help calm your mind and, enter into a safe space, whatever that might look like. And then, of course, medication is an option for our families or patients that might need additional support beyond therapy. We know that gold standard treatment, for example, for severe depression is therapy in conjunction to medication management services. So these are just a couple of recommendations from the mental health perspective. I want to say that was our last slide. Yeah, that's our last slide.
Well, thank you so much, both of you, for this thoughtful, in-depth, meaningful presentation. I know I learned much along the way. So thank you to you both. And we've had some questions. We have a few minutes, probably 5 minutes for questions. So a couple have come into the Q&A and a few others at registration. So the first question is, you mentioned Late effects can be seen typically 2 years post-treatment. And this individual has really struggled with these effects since the beginning, but they really became more pertinent now, 20 plus years post-treatment. Is it common to be noticing these effects so intensely, so far removed from treatment?
Yeah, I would say that's a good question. And I'm not giving any medical advice on here, of course, but I think it is common to really notice cognitive complaints, especially as you're getting older. And it's based off of this cognitive reserve hypothesis where we have so much brain power to give um, that when some is taken away at an early age, we have to compensate through other means. And so um, sometimes subjective memory complaints are just that, subjective, and sometimes neuropsychologically it comes out totally fine. Uh, and I would say late effects are something that is often reported and sometimes not even seen on cognitive testing, which is why we do the evaluation, is so that we can really measure and validate their experience, of course, but sometimes reassurance is necessary and sometimes intervention is necessary. So every individual is so different. It's such a heterogeneous population of what the impact may or may not have been. So it's hard to say.
May I add, Dr. Wiest, that there was an article that had mentioned that about 30% experience late effects even prior to treatment. 75% might experience late effects during treatment, and then about 35% of the population will continue to have late effects, even months or years to follow.
Thank you both. Another question that's come in, and this has to do with, you talked in such wonderful detail about cognitive dysfunction. And have you seen ADHD medications help with cognitive dysfunction, as well as some of the computerized programs that you mentioned?
For children with ADHD or
For the cognitive dysfunctions that have been caused by cancer treatment.
let's see. So I think the literature says that there's really no difference in symptom presentation with I believe it's stimulant medication and childhood cancer. That medication is really reserved for an ADHD diagnosis first and foremost. I believe I just read that a couple of days ago, actually. So,
You didn't know it, but you were preparing for
Yeah.
the question
I would.
in advance, right?
Yeah.
Um,
And I think the cognitive rehab part helps with the executive function skills that may have not been addressed, or part of the white matter tract dysfunction that we were talking about really helps put the building blocks in place. So it helps with sort of that subjective, again, that subjective report of executive dysfunction.
Correct. It like establishing compensatory
Yeah.
skills, right, to kind of help you buffer maybe some of your struggle areas.
and then when you were talking about the experience of the family, particularly loss and grief over normal family life, and and maybe this is something both of you could comment, what advice can you provide to families or recommendations for how to cope with that, um, loss and grief just over kind of normal family life. And now families are shifting in a new direction. I think you even mentioned that the Children's Oncology group had some recommendations as well, but I thought that was really so interesting. I wanted to go back to that to see uh, advice or recommendations from you.
Absolutely. I mean, I think many times there's different agencies or organizations have access to support groups for our families for grief and loss. I think bereavement, aside from bereavement, my apologies, it is important to help families explore the impact of what hopes and expectations they had for their child and children, I'm sorry, and the new adaptations that might have to come with that. Family therapy, I always think, is a very beneficial place to be able to explore some of the changes in systems or family dynamics, having to navigate different roles. Siblings, I think, oftentimes are often overlooked because there's an emphasis on the patient and their needs. So we strongly encourage family therapy, or if that commitment seems too scary, or because of there's financial potential barriers because of insurance, there are so many family resources. I mean, I think about you guys, Kathy, for cancer support community on, your parenting support groups, or just educational webinars that you guys offer to help support our families navigating these difficult and lifelong changes.
I'll add too that the grief is not just a singular grief and it's over. It's like a rock in your shoe, where it will come and be really, and it will swell, and it will be really hard in some moments and a little bit easier in others. And it's hard for siblings, for families, for parents, for the patient. It's hard for everyone. And at our hospital, at least, we see patients, we see therapy patients inpatient, and a lot of that is some behavioral work. And we run support groups as well with siblings and with parents, and with patients, and we have summer camps. It's why we have all of these supports in place, so that our families really feel heard and supported, just because of that revolving door that grief can feel like.
Absolutely.
That's such such a just the way that you framed that. I think but for both of you helps our family. So thank you for all of that you shared. I wish we could continue to have additional discussion, but unfortunately we have reached the end of our time together. And we've got one additional slide from Cancer Support Community that we'll put up, but I think, yeah, there we go. Doctors Vazquez and Wiest, I want to thank you for your meaningful presentation today, and for sharing this hour with us, and for sharing your expertise and just your practical learnings over the years as well. And I want to thank our attendees for your attention today, for your time, and for your great questions. As Dr. Vazquez shared, at Cancer Support Community, we do have a number of support groups to support families, to support parents and kids going through this. If you're interested in finding out more about those groups, you can email info@cancersupportla.org. You can visit our website as well, which is on this slide. You can also give us a call at 310-314-2555. And this summer, we have an 8-week series coming up called Creating Connections. It's not an 8-week series, 8 session. I think that's a more apt way to describe it. 8-session series over the summer coming up called Creating Connections for Kids and Teens ages 7 to 12. For the kids, and for the teens ages 13 to 17. And so if you know someone who is a kid or a teen who has cancer, they're welcome to attend, as well as if they have cancer in their family. They themselves don't have to have cancer, but just have someone in their family who has cancer. But these groups really provide a fun and safe space for participants to make new friends, to feel supported and understood by others going through the same things. So reach out if you would like to learn more about those groups or other groups that we have. We hope to see you at another webinar. And then additionally, if you would like a copy of the slides from today, you can also email us at info@cancersupportla.org. Thank you, everyone. Have a great rest of your week and hope to see you at another educational webinar soon. Take care.
Thank you.